So I think maybe we can take our break a little bit early and then we'll move ahead to hear from Department of Mental Health Services. Mental Health Services. And I will turn the meeting back over to you, Terry.
Yes, I wanted to thank Dr. Roberts and Linda Boyd, who are the key folks who have taken on the Care Court, both in a pilot form and then launching it full steam ahead. This was something that was approved by the legislature maybe 2 years ago, and it stands for Community Assistance, Recovery, and Empowerment Court. So it's kind of an in-between if you have someone who has severe mental illness instead of trying to get a legal guardianship or leaving them on the street or uncared for. This is a way to, with outreach, be able to pull someone into care and hopefully get them back into a balanced and normal situation again. And normal being probably a range of things, but it's trying to get people who need help get it sooner and have it be something that there's an actual plan for. And so I'm going to see if Jessica can pull up her slides here. And are these yours? This one's yours, right?
Yes,
Yeah,
it is.
it should be
Okay.
visible now. Yeah. Mhm.
Okay. Okay. There you go, Linda. All right. So I'm going to let you guys take over and explain all about the Care Court and how it's working at this point in time. At this point in time.
Thank you so much. Good morning. On behalf of Jessica and I, thank you so much for inviting us. Before I get into care, there were a couple of questions that came up in the last presentation, and I may be able to, I don't know about answer them, but shed a little bit of light. I also don't have the total number of beds that we have in LA County, but we are adding beds all of the time. And I also just was at a presentation where they were talking about the number of beds that we're adding, and we're adding beds at all levels of care. So, you know, we have the hospital, and then we have crisis residential beds. We have enriched residential services beds where the person lives there and gets their therapy, their medication, their case management, attend groups all the time, all the way to board and care homes. And then we have supportive housing where folks live and have a case manager, and then all the way to working with HUD to have folks live independently. So the department has a wide spectrum of housing that we do put folks in. The other thing is, when we talk about people being discharged from hospitals, one of the biggest issues is, and this is true for a lot of our programs, including Care Court, about 99% of the programs for the Department of Mental Health or for mental health in general are totally voluntary. So that if a person, what happens frequently with our clients, and I call them our folks because Jessica and I came into the business of treating folks with mental illness. So to me, they're our folks, they're my folks. So if I use that term, that's how I mean it. And so if a person is in a hospital and the hospitals by and large offer, if they don't have a home to go back to, they offer various types of programs that and housing that the client may be appropriate for. If the client says, I do not want any form of housing, I don't want to go anywhere, I'm going back to the street, the hospital has no choice. They have no legal ability or authority to be able to place that person in any kind of a residential setting, as much as we would love to, and as much as they would love to. So that's another thing. Department of Mental Health Services are free if people do not have insurance. We will, when a person is eligible, do everything we can to get that person on Medi-Cal. Having said that, undocumented folks are welcome. We do not ask people about their immigration status. People who don't have insurance can come to the Department of Mental Health. Now, we treat folks with serious mental illness. So if the mental illness, they may have some depression, but it's not super severe, we have managed care. We have other folks that we will refer those clients to, because our target population are folks with serious persistent mental illness. And the last thing before we get into care is the recruitment. And so you all know COVID changed work for everyone, including folks including mental health professionals. So now that COVID is over and folks are given a choice to be able to stay at home, do telehealth in the comfort of their living room or office or whatever, or come into the street and work with homeless folks or go into various types of housing, some of them clean, some of them not so much because of the illness. Many folks are choosing not to do field-based work. And many of the programs in the Department of Mental Health, particularly CARE, AOT, our home teams, full service partnerships that were mentioned before, all of those are field-based. We go where the client is. We go wherever they are to provide the services that are needed for them. So that's just sort of a broad response to some of the questions that I know were asked. So with that, let me start with CARE. And then, Jessica, thank you. So CARE Court, was, Mark Galley, who was, I think, Health and Human Services with the state, brought this to Governor Newsom, who liked it a lot. And it became law. And it was started in October 2023 with 7 counties. That was called the first cohort. The second cohort was due to start December 2024. LA County was in the second cohort because we wanted to have a chance to see exactly how it was going to pan out, how many clients we were going to get, to figure out all of the logistics. But because of the size of our county, folks wanted us to start earlier. So while the first 7 cohorts started in October of 2023, we started in December of 2023. So we've just celebrated our first anniversary. And so CARE was designed to treat folks specifically with a schizophrenia spectrum disorder. So included in that is unspecified psychosis, and we won't get into all of the technical things. But if you have family members who have bipolar disorder, for instance, that doesn't qualify for CARE. So it is a very narrow, the diagnostic criteria is rather narrow. It's in a way, it's a civil court, but really it's classified more as a collaborative court. And we're going to talk more about that later. But the 2 judges, Judge Renee Gilbertson and Judge Scott Heron, are very, 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 very client-oriented, family-oriented, and treatment-oriented. So everyone involved in the court system is all working together to help that client recover. And in CARE Court, that client is called a respondent. So you may hear us use terms interchangeably. And so everything about CARE is collaboration. The other misnomer is because it's called CARE Court, people think that there are consequences. CARE is totally voluntary. So the judge at some point is going to order the Department of Mental Health to provide services to that client. That client has the right to not accept the services. So it all depends greatly on the court piece depends on the black robe effect, what we call it. How much the client sort of respects the judge. The more they come to court, the more they see that it is supportive, the more they see how everyone cares for them. But everyone is working for their good, but there is no mandatory medication, which we'll talk about a little more. A lot of folks are referring their family members because they're hoping that they can get medication, and unfortunately they can't. So even though there's court in the act, and even though there's court in our name, there is nothing punitive. They're not remanded to treatment. They're not remanded to custody. We can't put them in a hospital unless they meet other strict criteria: danger to self, danger to others, gravely disabled. And that's a 5150, which any designated mental health professional can do if a client is in that kind of a crisis. Next slide, please. So what we do provide is we provide therapy, medication, whatever else that client needs. If they're unhoused, it's housing. If we need to help them get on Medi-Cal, an SSI, any other kind of benefits establishment, that's included. If they need substance use treatment, that's included. If they have an eating disorder, that's included. If they want to go to school, we work with the Department of Rehab. Whatever that client needs is what we are going to try to provide. And we do that by establishing a comprehensive treatment plan for each specific client. And we can get into the terminology. There's a section where it's called the care agreement, another time when it's called the care plan, and we'll get into that. But basically, it is a treatment plan specifically for that client. It is not conservatorship. And I think that might be why, Ms. Winters mentioned how we haven't gotten the number of petitions into care that was anticipated. And that's statewide, throughout the whole state of California, because now all of the cohorts, so care is mandated in every county in California. Every county must have a care program as of December 2024, when the second cohort started. So by law, every county has a program, and statewide, the numbers are not what was anticipated. And I think part of that is because a lot of folks were hoping that care would be, especially because it has the word court in it, that care would be a way to conservatorship. And again, everything in care is voluntary. And so it is not conservatorship. Next slide, please. I feel like Jessica's the Vanna White of this right now. Thank you. I appreciate you. So who qualifies for care? So later, Jessica's going to talk about who can refer. Who qualifies and who refers is part of the law. We don't have leeway about this. So it is for folks who are 18 years or older. So it's for adults. Again, the diagnostic is the diagnostic criteria is pretty narrow. It's for schizophrenia, schizoaffective disorder, unspecified psychosis. There's schizophreniform, schizotypal. I don't think we need to go into that, but it's all that schizophrenia spectrum, and then unspecified psychosis. So we all know folks have major depression, they have PTSD, we have a lot of folks who have bipolar disorder. None of those folks would qualify for the care program. They have to be, and they have to be not doing well. They're experiencing symptoms. They're not stabilized in their current treatment. So they may be going to a clinic and they may be seeing a case manager, for instance, but they're not seeing anybody else. And they're still being hospitalized. They're still coming in contact with law enforcement. And so they're just not doing well. Those folks qualify for care. They've experienced a significant decline in their mental health. So we sometimes have folks who are, they stay in their room. They shower, they eat. They're not a threat to anybody. They're not threatening themselves. And that's just sort of their baseline. They are eating, they are showering, they're not threatening anyone, but they kind of sit around. They're not deteriorating in any way, shape, or form. And while we all want them to get help, they may not qualify for care, depending if it starts to decline. But there are some folks who just do okay. And of course, we would love them to get care, to get services. They don't want any services. And those are the folks that are sometimes some of the hardest to differentiate, because we really, really want them to get care, but technically they're not deteriorating in any way. And that creates sort of a conundrum for us. They're unlikely to survive safely in the community without supervision, or we want to put them in care to prevent some relapse. So they start doing well, but we know that they're going to stop services and they're going to relapse, and we don't want that to happen. So before they start to relapse and end up needing to be hospitalized, we want to intervene at that point. That care is the least restrictive setting and that they are likely to benefit from care. And the other thing that's really, really important, because care has been touted as a way to get homeless folks off the streets. In fact, care is for anyone who meets the criteria. The housing status doesn't matter. And in fact, most of the petitions, and we're going to talk about petitions in a little bit, that's how, for the most part, that's how the whole process with CARE starts, is submitting paperwork to the court. Most of those petitions that we've received have been from family members. Many of those clients are housed, and they still qualify for care. Their housing status is not a determinant of whether they're accepted into the care court process. And if a person doesn't qualify for care, we try and do everything we can to get that person into another form of treatment, either a full service partnership. If they're homeless, they may end up going to our home team. So we do try to send them to other services to be able to get the support that they need. Next slide, please. So again, everything with CARE is voluntary. So they have a right to make their own decisions. One of the things that happens is, because you'll see in a few minutes that the whole process involves a number of court hearings. And in terms of court hearings, the setup is the same as with any other court. So county counsel represents the Department of Mental Health, and the clients also have their own attorneys. With CARE, those attorneys are with the Independent Defense Counsel's office. They're under the umbrella of the public defender, but they're a panel of private attorneys. And I believe there are about 50 of them who have signed on to defend our CARE clients. So at that point, they have their own defense attorney. DMH has county counsel who defends us. And then, of course, there is the judge. And that sounds very scary for a lot of folks, particularly since a lot of our clients have had some experience with the criminal justice system. What that does, in fact, is adds another layer of support for that client. Their attorney is involved with them. Even our county counsel is working to get that client the care they need. So everyone is working together in conjunction to get that client the services they need, so hopefully they can begin the road to recovery. So rather than being a punitive, it really adds another layer of support. Next slide, please. So this is basically what happens with CARE. And so a petition is filed, and we're going to go into how to do that in a minute. A petition is filed, and I can say there is some criteria that wasn't mentioned here. A person should be hospitalized at least twice on a 5250. So when someone is hospitalized involuntarily, we send them on what's called a 5150. That's good for 72 hours. If the doctors at the hospital feel like the client should remain in treatment and they're not willing to sign themselves, they're offered to stay voluntarily at that point. They don't want to stay voluntarily, and the doctor feels like they really need more care. After that first 72 hours, they're put on what's called a 14-day hold. And the welfare institution code that covers that is 5250. So the statute says that the client should have two 5250s, the last one being within the last 60 days, or an assessment or an attempt to evaluate this client by a licensed mental health professional the last time within the last 60 days. Many families don't know that. If their loved one is homeless and they're not always having contact, they may not know when they've been hospitalized. There's also HIPAA, which prevents mental health professionals from discussing the treatment and what's happening for clients without the client's consent. So right now, when families are filing petitions, the judges are putting the petitions through to us anyway. Even if those things aren't documented, the judges are putting those through. They've been very lenient. So what happens once that petition is filed, the court has been rejecting very few of those. they send it to the Department of Mental Health. And then we go out, our supervising psychologists, we have supervising psychologists, medical caseworkers, we have community health workers who have lived experience, we have psychiatrists, we have nurses. So we have staff who can offer the full spectrum of treatment to our clients. So the supervising psychologists will go out and do an assessment and talk to the clients. We start outreach as soon as our medical caseworkers, senior community health workers go out as soon as we get the referral, usually which is within a few days of the petition being filed with the court. Then as I said, our supervising psychologists go out and do an evaluation, and they determine whether that person meets care criteria. Once they've determined that, they write a report to the court, and then we begin the outreach. Then we develop a treatment plan for that client. The client signs off on that treatment plan. And after that, there are review hearings or status hearings. So the client and it's supposed to be no less than 60. The maximum time is every 60 days. If it happened every 60 days, we would be very happy. But the judges are ordering reports. They want to know more information. How are you doing with getting the client housing? How are you doing with getting the client benefits? So I'm saying the judges are very, very, very involved. And so we're ending up going back to court with clients every 2 weeks, every 3 weeks. It depends on the client's needs and how well the client is doing. So once the care plan, that treatment plan has been signed off on, the judge approves it and orders it. And at that point, that's when the clock starts ticking for care. So care is a 12-month program. So at the 11th month, we all meet again, and we're meeting through the reports. But again, a decision is made. Can that client graduate? Can they step down to a lower level of care? They can volunteer to stay in care for another year, or they haven't been as successful as we would hoped they would have been, and we can repetition them to stay in care for another year. Anywhere along the line, if the client is doing extremely well and everybody agrees that they can step down, the judge has the option to dismiss it, and we put them in a lower level of care. We haven't had any graduations yet. Excuse me, I believe our first graduation is in February. So we haven't experienced the graduations yet. Next slide, please. So if the client agrees to that treatment plan and says, oh yeah, I'm on board, it's called a care agreement. If the client does not agree to that plan and they say, pound sand, I don't want anything to do with any of this, then once it is approved, it's called a care plan. All care agreements or plans include therapy, behavioral health services, therapy, case management, medication, and then housing resources. We've found that some folks are housed and they're housed with families, but it's just not working out. It's super, super stressful for the family. It's very, very stressful for the client, and they would be better served in a different setting. So even though a person is housed, it doesn't mean that we're still not, for some folks, we're still not looking for other housing resources for them, because they would just do better somewhere else. And then again, whatever social services and supports they need, these things are a part of every care agreement or care plan. Next slide, please. So here you see the complexity. And let me just say, I forgot to mention, well, I'll do it through here. So you can see there are two triangles on the left-hand side. And so the gray are petitioners. The Department of Mental Health, if we do have an internal process for folks who are in the Department of Mental Health or our legal entities. So for instance, Ms. Winters mentioned our law enforcement mental health teams. They can do an internal referral. Our psychiatric mobile crisis teams, they do internal referrals. Department of Health Services does internal referrals. So with those, we don't need to go out and see if the person meets criteria. We already know they meet criteria. We vet that And if we feel they meet criteria, we file the petition. So all of this starts with the petition, whether the Department of Mental Health files it or whether it comes from family members, and Jessica's going to go up to who can refer. So the judges look at the prima facie. Does it meet care criteria? And again, they're not looking so much about if they've gotten the hospitalizations and stuff. They're letting those go through. So if you're thinking about petitioning someone, don't worry about that for right now, because they are letting those go through. And then once we so then we go out and do an evaluation, as I said, and we write a report to the court. And then there is an initial hearing. One of the things, so the person who petitioned must come to court, and court can be on WebEx. You don't have to come in person. And the Department of Mental Health is there. Hopefully the client will attend as well. And if the client doesn't want to come to court, our staff will go out with our laptops and put them on WebEx if they're willing to do that. Or we will bring them to court. The team will drive them to court. So we will, if they want to come either way, and most of the clients are appearing, I think. At that hearing, the judge dismisses the person who filed the petition and makes the Department of Mental Health the petitioner. So then all clients in care have the right to pick a supporter. And that's very unique. That doesn't happen in other programs. So it's ordered that a client can pick a supporter. Very interesting to me. This part's not as interesting, but the judge asks the client if they want, say mom petitioned their son. And the judge will say, once the mom is discharged as the petitioner, and now the Department of Mental Health is the person who's picking up the baton for the rest of the process, the judge will say to John, would you like your mother to be your supporter? I thought because they were being petitioned by that person, they probably weren't going to want that person as their supporter. Interestingly enough, a large number of our clients do pick the person who petitioned them as their supporter. Sometimes not, but much more often than I anticipated. That supporter has a right to be noticed of every single hearing, to be as involved in that client's treatment as the client allows. So if that client wants them involved in everything, in therapy, in case management, in all of it, that supporter gets to be involved. If they don't want the petitioner, they get to choose who they would like as their supporter. Now, if they want their local drug dealer, the judge is not going to allow that. So there is a little bit of vetting about who can be the supporter. Some clients choose to not have a supporter, but this is very unique because most programs don't have this option or ability. So at that initial hearing, if the client is willing to participate in the program, it goes right to developing a care plan, that care agreement that we talked about. Then they will come back to court, and the judges sometimes add things to that care agreement. Well, have you thought about this? And I would like this added. When the judge signs that care agreement, that's when the 12 months start. The client says, I don't want anything. Okay. And the care agreement must be in collaboration, not only with the client, but also with the client's attorney. So everybody has to sign off. The client sign, the Department of Mental Health, the client's attorney all sign off. And then the judge approves it. And that's when it happens. Some of our clients say, I don't want anything from you, go away. In which case we have a hearing of the merits. With the hearing of the merits, it determines, does that person meet criteria? So before that hearing, our supervising psychologists go out again and do another evaluation to again maintain that client still meets care criteria. Now, the Department of Mental Health is going to probably, in all likelihood, present that same treatment plan that we presented with the care agreement, because those are the services we think the client would benefit from. And if the client wants to add more services, that's great. Clients with care plans tend to not want to add services because they don't want the treatment. It goes back, again, the ICHO attorney and the client can determine what they would like in the treatment plan. We both present it to the judge. The judge determines that care plan and signs off on it. And the Department of Mental Health is ordered to provide those services to the client. After that time, there are status reports or progress reports. So they're called progress report for the care agreement, status reports, the care plan. And again, at the 11th month, a determination is made about whether the client is able to graduate, stays voluntarily, or is repetitioned. So let me pass the baton to Jessica.
Thanks, Linda. That was Linda Boyd, y'all, one of our fabulous district chiefs over the Care Court program. So we have one in the north and one in the south. Linda is with us here in the south region of LA County. My name's Jessica Roberts. I'm a psychologist with Care Court program. I oversee the service area 6. We're broken up into 8 service areas in LA County. Service area 6 is the Compton area. So South LA area. And then I also assist with service area 5. That's, Santa Monica all the way up to Hollywood. So thank you for having us. Super glad to be here. Let's talk about who can petition, because I got a great question about, are petitions only coming from like the criminal justice system? And that's not the case. As Linda started talking about, petitions can come, anybody can petition. So we have family members, the respondent themselves. So a person can actually self-petition themselves. I think on my caseload, at least 2 of those folks that submitted their own petition for services and wanting support. We get petitions from lots of people in the community. So first responders, our psychiatric mobile response teams can also petition, or they also have the avenue of doing an internal referral. We get these petitions from hospitals, from people's primary care physicians. It can also come from if they're already being seen in treatment, but perhaps they're not doing well, or they are deteriorating. Their treatment providers, like their therapists, can also petition. County-wise, we've got the county behavioral health folks. We do get petitions from the public guardian's office as well too. I like the system that we've sort of set up too with the public guardian's office. Care Court's a great way to step down from conservatorship. So we have folks that are going to, their conservatorship is getting ready to be over. I have a gentleman I just met with the other week. His conservatorship is ending. Care Court kind of provides a really nice safety net, because these are field-based services, and we can, wrap those services around him as he's transitioning out of conservatorship and being more independent and living independently. So, so we do get petitions from Public Guardian as well, and the Director of Adult Protective Services from tribal jurisdictions as well. So from the judge of a tribal court or the director of a California Indian Health Services program. And I apologize if you see me looking over. I got 2 screens going on, so I realize I'm looking over here. And then recently, in the last couple of months, we also started receiving petitions from prisons. So from the California Department of Corrections, as well as our state hospitals. So Metropolitan State Hospital, Napa State Hospital, all the way, from anywhere really. So we have a couple of those petitions as well too. All right. So how does one file a Care Court petition? If you had a loved one, or you have somebody that you're working with that you think needs this higher level of care and meets that, criteria that we went over, there are 2 basic forms for Care Court. There's one called the Care 100. This gives all, the basic information about this individual and why they may need these services. People can also include evidence to this, so they can attach maybe past hospitalizations, like, if there's a discharge plan that they got from the hospital, they can attach that to kind of show that this person has this history of mental health services, but they're deteriorating and they really kind of need this higher level of care. There's also a Care 101 form that's required. This comes from a licensed behavioral health provider. So some of our clients do have somebody like a therapist or, in their life that's able to fill that out. If that part is not there, then part of what we get ordered to do as Department of Mental Health is to make sure that that person meets that criteria. So we go out and do that as well. These forms, by the way, are provided in multiple languages. And if we have time at the end, I'll show you all the website where all of this stuff lives, where these forms live and how to fill them out and all that kind of stuff. There's several different locations for filing a petition and also for receiving help to file a petition. Doing any kind of court documentation can be really daunting. It is several, it's a couple pages. It's not a huge packet, but it's a couple pages long. So folks that are unsure can get help. We do have a self-help center. The phone number is listed there. There's also the website. And then this map shows you where all of these different places are, where a petition can be filed. There are kiosks that are at these places. And then in Norwalk is where we actually have Care Court right now. So that's sort of the central hub of Care Court. That's where all of the hearings occur. And we also have a self-help center that's on the 7th floor of the courthouse there, where people can go in person and they can be assisted in filling out a petition. In fact, I think both of our self-petition folks, they actually came to the courthouse and self-helped help them fill out a petition for themselves because they were wanting services. So that's in the Norwalk area. I think that's, yeah, right here, number 6. So the Norwalk courthouse is listed there as well. So what happens after you file a petition? You submit this petition. There's a review of that petition, like Linda mentioned, to see if if that basic criteria is there. There's also initial outreach that starts happening. So the team will start reaching out to the petitioner, and again, that could be the primary care physician. It could be a family member. It could be the person themselves wanting services. So we reach out and we start engaging with that person so that we can meet them and do this in-field assessment to see what exactly it is that they need. Do they meet our criteria? Also, again, as Linda mentioned, and you're going to see a slide on this later, the Department of Mental Health is always trying to work with people to make sure that they get the services that they need at the lowest level of care possible, the least restrictive. So we want folks to maintain their autonomy, their independence, their sense of empowerment for themselves. So if we're able to, we meet with an individual and they are receiving services already, and we're able to help reconnect them to those services and sort of bridge that gap that's been going on, then they may not need the Care Court program. They may not need continued assistance if we, help them get back on track with that as well. So we assess for, multiple things when we go out. As Linda mentioned, there's an eligibility hearing that happens. This is also where somebody can be, the participant can select a supporter. Somebody mentioned court-appointed advocates. I have seen some court-appointed advocates that come into the courtroom, and that is available. Most of our folks, like Linda mentioned, they actually tend to pick somebody in their life. They actually do tend to pick a family member. Not everybody. But a lot of our folks do pick whoever it was that petitioned them, mom, dad, auntie, grandma, and that's their person. I should clarify too, that supporter role is just that. It's a supporter role. So although you may have submitted a petition for your loved one and they have now listed you as a supporter, it means that you're able to come to the hearings, you're able to participate in terms of being, part of that person's treatment team, but you are not driving the treatment. So you don't get it is still their treatment. It's still their treatment plan, and they make all of those decisions. Same with the court. You could be a supporter, but it's definitely not about you or what it is that you're wanting. However, the judges are wonderful and fabulous about making sure that family members are heard and their concerns are heard. And then we work, again, collaboratively and collectively. At some point, that petitioner's role, as Linda mentioned, is given over to DMH. So we do have people that have petitioned, and then they kind of back off and they let DMH take over, and they want that help for their loved one. And perhaps their loved one's not interested in them being, the participant's not interested in them being a supporter. The DMH just takes that role over. This another, I'm a big visual gal, so I like visuals, and I like this one as well. It kind of sort of shows you this process where that case initiation happens, that petition is filed, that prima facie determination, do they meet the basic criteria? As Linda mentioned, our criteria is actually a bit narrow. And don't worry, we're going to have some resources that we'll go over at the end, because although we're seeing folks on that schizophrenia spectrum, the department has oodles and oodles of resources. We've got all sorts of programs, wonderful programs that are out there for people of all ages, and people dealing with all sorts of mental health concerns. So this prima facie is seeing if they meet that narrow criteria for Care Court. The department can get ordered to do an investigation if everybody's feeling like we need more information. Do we need to find some additional records for this individual to see if they meet our criteria? So that can happen, and then we move on to that initial hearing and what we call a hearing on the merits. So this is where we are, we're letting the court know that this person does meet our basic criteria. What's really wonderful about this hearing and what we try to do before we get to this initial hearing is do a lot of outreach with the individual. So by the time they get to that initial hearing, oftentimes they are stipulating to meeting criteria themselves. To saying that, you know, they do want services, they are wanting assistance. We work really hard to try to make this as collaborative as possible. Does that happen every time? Not every time. So sometimes as a supervising psychologist or some of us may have to testify on behalf of this person, letting the court know that they do, in fact, although they may not be interested in services, this is somebody that really does meet our criteria and really does need our help. And we would like to move forward with, you know, trying to provide them services. Keep in mind too, during this entire process, they are represented. They have legal representation. So if they feel very strongly about not having, I do not want the department coming here anymore, I'm not interested, that's what their attorney is there for, to help protect their rights. Linda mentioned we do have case management hearings. These can be, there's kind of several things that can happen with case management hearings. So either there can be a clinical evaluation that got ordered to see exactly what kind of services this person might need or what's going on. Also care plan review. So if we weren't able to do a care agreement with somebody where we're working collaboratively, but we put in place a care plan, we might review that. Case management hearings can also, as Linda mentioned, sometimes they can come up every couple of weeks or every, you know, once a month. And it could be like Linda mentioned, the judge is just very interested in, have we gotten this person housing? Are they in some type of interim housing? Have we got this person connected with a medication evaluation? So those happen. These status and progress review hearings, those are the ones that are happening at a minimum every 60 days. So we have some folks that are doing really, really well, and they don't really need those in between case management hearings, but they're absolutely, one is getting set every 60 days to check in to see, is the care agreement still working? Do they need additional things? Because as they continue to stabilize, there may be some additional things that come up. Hey, you know, Dr. Roberts, now I've been on medication. I've been getting my shot for a while. I'm really interested in individual therapy. I want to start talking to somebody one-on-one. And so we can add that to the care agreement. Both the care agreement and care plan can be amended at any time to add additional services as the client, you know, asks for them. And then, of course, we're working towards that graduation. So where do you find all of these things? We have one website. It's a fabulous website. You can use your phone to scan the QR code right now if you like. It is a mobile friendly. So if you scan with your phone right now, it shows up really nice. Not, you know, some websites are not so mobile friendly. Ours is mobile friendly, so you can check it out. It does come, you are able to access it in multiple languages. There's a frequently asked questions section on there. And like I said, if we've got time at the end, I can kind of show you a little bit about what that looks like. There's a super helpful video that helps explain Care Court to anybody that accesses this website. So you can provide this website to anybody, family, friends, you know, people in your community, and it's a great place to get started. And then there's multiple downloadable resources that are available too. We also have a group email, which is the best way to get a hold of all of us. So instead of trying to individually get a hold of Linda or myself, if you have a question, which you're welcome to do, you can actually use our group email to get in contact with us. And it can always be navigated to us. It does get triaged by staff. So if you have a question that's specific to Linda or myself, you can use the group email and it would be triaged to one of us. So if you ever have any questions or you have community members or folks that have questions, you're welcome to use that group email. So I mentioned that, you know, Care Court may not be for everybody, but it doesn't mean that we don't have lots of different types of resources. And I especially like this visual because it shows you how we do try to work, you know, we try to keep people in the least restrictive in terms of their treatment. Now, the most restrictive all the way on the left-hand side are oftentimes those reentry type services. So it might be somebody that's at an IMD or an Institute for Mental Disease. Some of those are locked facilities. Those may also be people that are under conservatorship in that locked facility. We mentioned hospitalizations like 5150s. Those are also not voluntary. So somebody is being kept at the hospital for a period of time for observation. And Linda talked about how that can be extended based on the need and how the person is presenting. Then we move into our home folks, which they've been around for quite a while, and they are some of the most dedicated. When Linda mentioned we have so many people that have not been interested in doing field-based services, our home folks have been hitting the streets for years and years and years, and they are just some of the most fabulous clinicians and team members that you'll meet out in the community. It is a county-wide program, so we have this in all service areas. It stands for Homeless Outreach and Mobile Engagement. It is voluntary, but the home team, we're working right now with them on a client that they're seeing daily. They're going out every day to see this person to make sure that, you know, they're taking their medication, because we really do want to try to prevent those restrictive levels of care. We want to keep people in the least restrictive. Some of the other programs that you'll see in terms of crisis stabilization here at the bottom is our enhanced residential services as well too. This is voluntary. Some of this comes, it's a higher level of care in the sense that it's typically staffed. So some of these places are staffed with nursing staff, and because that person they may have some medical issues along with mental health issues. So we have enhanced residential services. We also have crisis residential treatment program. These are also places that folks can get placed, and there's a level of support and supervision that surrounds them there. Our AOT program, which Linda's instrumental in AOT. She is the guru of AOT. So if you have specific questions about AOT, I would shoot them Linda's way. The assisted outpatient treatment program is also available to folks. The criteria is a bit different. I won't get into super specifics, but it is a little bit different, and it is a higher level of care. It does go through the court system as well, or it can. It starts out voluntary. Again, we're always trying to collaborate with clients and work with them at that least restrictive. So AOT is about connecting them with a specialized full service partnership program that will provide those services. But at some point, if they are not engaging in those services and they're deteriorating, or they need that, you know, some extra support, then AOT has a means of being able to appeal to the court for the support that they need. Then we move into our program. That's the Community Assistance Recovery and Empowerment Act. Again, 100% voluntary. It's also 100% field-based. I should add, we have two fabulous psychiatrists that are a part of our team, one in the north and one in the south. So when I mean field-based, I mean we are all going out in the field, including our fabulous psychiatrists, and we're hiring some more as we move along too. We just hit that 1-year birthday, so we've got more hiring to do. But the whole team is out there and meeting people literally and figuratively where they are at. Our full service partnerships are also, we have some directly operated full service partnerships through DMH. We also have some fabulous contract providers that provide FSP. This is also field-based as well too, but it doesn't have that black robe effect the way that CareCourt has. So, but we do, sometimes that is the more appropriate level of care for some of our folks. There's also outpatient treatment, as well as outpatient treatment, both field-based, but also both clinic-based. So an individual's making their appointments and they're going in on a regular basis. So we've got a spectrum, and we also have services that are geared towards certain groups of people, certain demographics of people. We try to be as inclusive as possible. So we have our transitional aged youth folks, we have older adult folks. So we try to gear our programming towards folks. Internally within CareCourt, we try to do the same things. On my caseload right now, my youngest is 19 and the oldest client I have is 71. So, and I've got folks everywhere in between. But what we try to connect them to is the programming that makes the most sense for them. So for the 19-year-old, I'm looking, we're looking for interim housing that would put him with an age group that's more appropriate for him versus putting him with a bunch of older adult males. Maybe that may not be the best idea. So each treatment plan is very specific and unique to each client that we're working with. And we work collaboratively within the department as well as with our partners as well too. The hospitals, Department of Health Services, our law enforcement folks. We're working with a lot of folks. These other avenues of support. So if for some reason your loved one's care petition does not get accepted, again, there's so many different ways of getting support for folks. And some of this was mentioned by Ms. Winters earlier as well too. So of course, 211 has been around forever. You can call 211 for all sorts of things, shelters, whatever services that you might be needing. We have text LA. We also have our access line. Our access line, the 1-800-854-7771, is available 24/7, and you can call. People can get a screening over the phone to see what sort of services they might need, and then they get directed to those services. It's also there is to get directed to crisis response teams. So like our psychiatric mobile response teams, you can call the access line for that. And of course, there's 988, the crisis suicide hotline as well too, that folks can connect to. We've included the website up here for Get Help Now that kind of directs you to some of these things. But there are multiple resources. And I should clarify too, these are resources we also give all of our clients and their families as well too, because Care Court, we are a field-based treatment team, but we are not a crisis team. So we make sure that our folks have all the resources they need. So in the event that something happens over the weekend or after hours, that our families and our clients feel supported and they know who to reach out to and get services from in that moment, because we know things don't just happen between, bank hours, right? It's not just 9 to 5. There's things that happen all the time. So we've got wraparound services that include these crisis services, and our folks know how to be able to access and use these things. And we work collaboratively with those teams as well, too. All right. So let me, do we have time or should we do questions? I'll defer to Terry.
I think we have time.
Oh, okay. Let me show you all the website just real quick so you can kind of see. And I apologize. I should have made this a little bit bigger. Let me kind of blow it up a little bit. So this is our Care Court website that we have that anybody can access. Also up there, you'll notice the Get Help Now. That'll take you directly to that page where all of those additional resources are listed as well too. So that's on that page. But this tells you more about the program. I'm just going to scroll slowly so as to not, for our motion sickness folks, I know I get motion sickness. I'll scroll slowly here. Here is the video. So it's a really great, super short video, but it tells you about the process, gives you sort of an introduction to Care Court. It also includes links to additional resources. And here's where you can find, frequently asked questions. Does somebody, how do I know if somebody is eligible for Care Court, and then how to access some of those forms? All of that is listed there as well. You can learn more from the LA Superior Court website. They have their own Care Court website as well. So that's an additional resource that's there. All right. I'll scroll back up here. And somebody asked earlier too, we'll make sure to share these, the slides and our information, like our group email and things like that with Terry, and so that you all have these slides and this information as well too.
Yes, we can send it out to all the registrants after today.
Wonderful.
That way people have it right at their fingertips. You guys have been fantastic. This is a complicated situation, and I know there was concern when they were talking about the bill that this may be too restrictive. There was fear that people were going to end up in those locked facilities. And from what you've seen and what we're seeing here, as Linda had stressed, it's voluntary. Everyone's getting involved and doing what they can at their own level. What is your caseload?
Well, Linda can speak to like the larger numbers. I can tell you from, to give you the numbers for service area 5 and 6, we've got 42 clients between 5 and 6 right now. We have, of the 42 folks, we have 16 care agreements, 7 care agreements that are pending, meaning that they're just waiting to get approved by the court, and 1 care plan. This is an individual that, again, is not super keen on services, but we want to keep going out and providing support to her and her family. So there is 1 care plan. So out of the 42, having half the folks have a plan or a care agreement in place has been wonderful. Those other folks, it may be that they're just still in outreach and engagement, or it may be that we're working on either a higher level of care or a lower level of care. We do have some folks that do need that higher level of care, and we work very closely with the hospitals when that happens. I just visited a woman yesterday she has a heart condition, and she does not believe that she has a heart condition, and she is in stage 4 heart failure. Because her situation is very, very life threatening. At this time, that higher level of care is what's going to help keep her alive and thriving. So we're working together with the hospital, and we visit her, and she is on that track towards conservatorship. Her family is very much involved as well too. So that does happen, but we're trying really hard. And our program is about reducing incarcerations, reducing hospitalizations, and preventing conservatorship if we can help folks be able to survive and thrive in their community and with their loved ones. That's what we would like to do.
So I can say that I remember the exact number. We have about 320 petitions and about 130 or so referrals at the present time. And then someone in the chat just asked, how do we get someone with severe mental illness to participate in their own treatment if this is all voluntary? And that is, I'm old enough to remember the $64,000 question. Now it's probably the billion dollar question. Many of our folks, both with AOT and with care and with home, which are all sort of more intensive in terms of treatment, don't believe they have a mental illness. So for folks with schizophrenia, that's very common. It's called anosognosia, specifically. It's very difficult. And so it takes a lot of time to sort of build up trust. Just if they're anxious, we sort of approach it from, we can help you with that anxiety. We try and approach it any way we possibly can to kind of normalize what's happening for them, so that, and it comes with that intensive outreach, and that, folks say, go away, we don't want you, I don't want to ever see you. We say, great, we'll come back next week, we'll come back tomorrow, whatever it is. We also have credit cards that we're able to buy food, we're able to buy clothing. If they have other specific needs, we have certain money limits. And, if someone's willing to accept some services and they're homeless and we don't have a bed immediately, we're able to put them in motels. So we do have some things that can help us engage the client. And the more we're able to, sometimes folks will only talk to us as long as it takes them to finish the meal. So they may stay, what can we get? Are you hungry? What would you like? We buy them. I want McDonald's. They may talk to us only as long as it takes them to finish that, double cheeseburger, but we take it. And so often the fact that we keep coming back and coming back and coming back, and that we are willing to buy them food. Are you cold? Let me get you a coat. It's, we're starting now today, I guess, into the rainy season. So we do whatever we can to establish it's all about relationship. And to be very transparent, and you all know this, there are just some folks that are not going to engage. But the teams are, I can't say enough. You hear from Dr. Roberts how wonderful she is. And our teams are great. They're willing to go above and beyond. And, the 71-year-old person that Dr. Roberts mentioned was housed near the fire area. So on the weekend, the case manager who'd been working with her went out on the weekends to make sure she was okay, to see if she needed to go to another motel. We had placed her in the motel, and while we were waiting for housing had been approved. We were just waiting for the bed. And so he went out every day of the weekend to make sure that she was taken care of. So while we're not an emergency service, our staff are very willing to do whatever is necessary to make sure that our clients are cared for. I cannot say enough about how hard they work, how dedicated they are, and how much they care about our folks.
I would add too, I think sometimes it helps to provide, one of the things I really like about this program is how even more involved we are with families, because we do have just so many petitions that we get from family members that have sort of been feeling as though they've been let down, over the years, or they've been held hostage, by their loved one with this severe mental illness. So helping to provide some psychoeducation is helpful. It is all about that consistency piece and meeting that individual where they're at. I did have a gentleman that very politely every time, please do not come here. Please, I do not want services. Every week we went out. And this has taken, we are 6+ months in, and have just now he got to the point of like, well, I guess if you're going to come anyway. So sometimes it's just staying engaged. It's also letting them know that it isn't just it's support for them, but it's support for their loved ones, which kind of helps put things in perspective sometimes for them. But really the key feature is the consistency piece, is we just keep going. And of course, short of harassment, we're not going to harass anybody, and again, it's voluntary services, so we can't make anybody engage in services either. But it's a collective effort. One of the other things that's really helpful in engaging folks is we have multidisciplinary teams. So we have folks on our teams with lived experience. Either they themselves have been through treatment, substance use treatment, mental health treatment, both, or they have had loved ones themselves go through treatment. We have substance use counselors, medical caseworkers. And so sometimes it's all about who they connect with on the team. I can go out as Dr. Roberts, but maybe they've really been burned by a lot of docs and they're not interested in meeting with anybody with that title, right? But they could meet, with their case manager, who is a senior community health worker or a peer, and it really resonates with them and they're able to connect with them. We have a gentleman that just finally agreed to go into residential substance use treatment. And I think part of that was having somebody on the team that was, that had that lived experience, and they were able to make that connection. So that's one of the other tools that we have that I think is really helpful, is having that multidisciplinary team. Somebody asked about ages. It is 18 years and older. I think one of our oldest clients actually in Care Court is, and I might be wrong, Linda, but I think 83. We have an 83-year-old gentleman, a part of Care Court. He might be our oldest that we have, but it's 18 years and older.
And, to reiterate what Jessica was saying, that I think the we're not going to give up attitude. So sometimes the client says, okay, you're coming anyway. But the other thing is they begin to see that, because for a lot of these clients, some of them have very involved family members. Others don't have anybody. And we stick it out. So you swear at us, we're coming back. You tell us to get away, we're coming back. You matter to us, we're not giving up on you. And at first they probably see it as harassment, but the more we come, you go to jail, we're going to see you in jail. You go to the hospital, we're going to see you in the hospital. We are not giving up. And I think that for a lot of clients who've had a lot of disappointment in their life, they begin to see, wow, these folks really do care about me. I really do matter to somebody. And that helps a lot. One thing about our access line, that 800 number, the other thing we have is a warm line for veterans. We have a veterans line. So if you know veterans who are experiencing difficulty, that is also 24/7. So I wanted to mention that. And I believe in LA City, it's LA County's 211. I believe LA, and I think they will handle the city as well, but I know the city also has a 311 number.
Thank you for all you guys do. This sounds like such a caring career that you are in. It's not really a career. It's something that you do because you really do want to help people, and that comes through in your presentation. Lots of information, but also just that sense of caring, and we know that's what those folks need. So we appreciate that, and for you to take time on Saturday to come and talk to us as well.
Thank you so much for having us. Thank you.
Thank you for being here. Are there any other questions before we let these ladies go on with their weekend? All right. I think we're good.
Thank you so much. Stay safe,
Thank you
everyone.
so much.
Thank
Yes,
you.
stay safe. Thank you.
Yep.
Bye-bye.
Bye.
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 As you have been reassured, local leagues will be receiving information about the recording and the contact email addresses, website addresses, and so forth, so that you can share this with your own members and have it as a resource to utilize in the future. And you may be wanting to have a mental health program within your own local league. I know the Palos Verdes area group has been studying mental health and mental health services and have been very helpful in this program. And in addition, the league is following the implementation of Care Court. We will be monitoring, interacting with the Board of Supervisors when it's appropriate to lend our support and our aid in making sure that this program is funded and is supported by the Board of Supervisors. And we will, I will defer to our more techie people to let you know where this will be posted. One place should be our LA County website, which is lwvlac.org. And the slides may be sent to all the people who actually attended today. So those are two resources that you'll have.
Beach Cities will
So thank you all.
probably-
Pardon me?
Beach Cities will probably post the slide, be able to post the slides and the recording if we can get the recording from you as well, so we can share that.
Very good. So local leagues will be able to utilize the recordings on their own websites, Beach Cities in particular, since they were instrumental in making this program happen today. So we thank all of you for attending. We hope that this was useful information that you will be able to tap into. And a reminder again, please join us at our County League Convention on March 29th. More information will be coming directly to your presidents and through the county voter as it is available. And it will be a live meeting. We hope that you choose to join us because this is an opportunity to network not only on mental health services, but on many other issues that leagues are interested in. I'd like to thank people who made this webinar possible. Terry Newstetter for putting together all the speakers and making sure that we have their contact information. And Martha Zavala for being our background tech person who makes these webinars happen.
Yeah.
So again, thank you to everyone and have a good weekend.